what I thought would be useful to do, because there's so much new information coming at us every day, and we interpret it, with alarm, sometimes positive, and the stock market goes up, and sometimes negative, like today, I guess, and the stock market's going down. It's kind of hard to figure out what to do with this fire hose of information. So what I thought I might try to do is just give a framework to kind of put the information as it comes in context. A lot of what's going to go on with the macroeconomy will obviously depend on what happens with the progression of this disease. Some of what will determine what happens with the progression of this disease is public policy. And so all along, we're going to have governors and the president and mayors weighing the costs and benefits of social distancing and making decisions about how to proceed. And those decisions are going to have a big impact on what happens to the macroeconomy. And then, of course, we all have questions about second waves, and is this going to come in the future? So what I'd like to try to discuss is first just a snapshot. We hear announcements that we're bending the curve. What have we achieved with the social distancing that we're undergoing now? And perhaps more importantly, the second question is, what are the public health experts hoping that we might achieve when they're giving recommendations about social distancing? What's the target? What's the quantitative target they're aiming for? So that's the second question I want to discuss. And then we have a counterfactual, though I guess in Georgia, it might not be a counterfactual. What's going to happen if in the near term we abandon social distancing in terms of the progression of the disease? We also have to prepare ourselves to think about the counterfactual. If we do that, how are people going to react? Would we actually get much of an economic benefit if we did abandon social distancing now? Because would people actually choose to go back to work and spending? There's some historical data on that I think is relevant. A lot of the discussion of the costs and benefits has to do with the question of what's the fatality rate of this disease, and perhaps could we have more targeted interventions to protect the vulnerable. And perhaps the biggest mystery is, what are the long-term scenarios for this disease, this fall, next year, the year after that, etc. And so, at the end, I guess every day we each have to try to put this together to weigh the costs and benefits of social distancing and make projections about what's going to happen. So I'll conclude with a little bit of discussion of that. So let me just start with laying the groundwork. Jim mentioned, I actually, was rather alarmed when Angela Merkel came out about March 10th and said 2/3 of Germans were going to get this disease. And that's, what caused me to say, boy, we really have to figure out what's going on. And, in the United States, we hit 1,000 deaths on March 26th. And we've had 5 doublings of that to 32,000 deaths by April 15th. And so at one level, if you think about trying to make forecasts about what's going to go on, I kind of joke that this is like valuing a very fast growing company like Tesla, or say, Apple when they first issued iPhones. It seems like the sky's the limit for what might happen until we can figure out what's going to cut off this exponential growth. Now we have good news, not just in the United States. This is a graph that is showing on a logarithmic scale, the same as what I had on the previous graph, of what's happening to cumulative deaths around the world, measured in days since the country hit the 25th death. And you could see for all the countries highlighted in this graph that there's been a bending of this curve. So countries that were growing initially with doubling times of every 2 or 3 days are now seem to be bending down to be, say, once a week or even slower than that. And so this is quite good news. And most of these countries have implemented social distancing, some of them perhaps less so than others. And this has meant that what we see when we look at the growth rate of deaths on a daily basis, that we're coming down from, say, like a daily growth rate of 30% to something that's considerably slower. And we hope that we could say we could causally attribute this to the social distancing. There is always the possibility that this is just something going on in nature that's slowing down the progression of the disease globally, and maybe it would come back. But we hope that this is the causal result of our social distancing. So you'll hear forecasts of what's going to happen. In the state of Washington, the group, the IMHE modeling group that gets a lot of attention from the White House, is forecasting 60,000 deaths by August 1st. And so clearly that's a dramatic slowing in the growth rate of cumulative deaths that are forecast. And you might ask, where's that forecast coming from? Is it some complex structural model, disease model that they're using? I think Bob Hall, who is of course very prominent here at the NBER, has shown that no, you can actually reproduce their forecast pretty simply. So what Bob Hall does is he looks at the data for the growth rate of cumulative deaths on a daily basis. And so that's the red line that's bouncing up and down as the data comes in. And that growth rate is clearly declining, as what we've seen. And so he just fits a line through that growth rate. That's the blue line you see at the graph. And then the growth rate can't go below 0, so he makes it look like this hockey stick. When it hits 0, it goes flat. And so that implies, a very dramatic slowing in the progression of the disease. And the Washington state, and the model coming out of the IMHE group, that's shown in the curve in red. This is their April 17th forecast, with the pink shaded error being the uncertainty bounds around it. So you could see that, a rough rule of thumb is they're essentially forecasting a continuation of the slowdown in the growth rate of deaths that we've been seeing so far. Now, so what's the goal? Like, how long are we supposed to do this social distancing, and what are we trying to achieve? And so on April 17th, when they did their new forecast, this IMHE group came out and stated a quantitative goal, which I think is quite interesting to think about. They're looking to get the prevalence of the disease down to 1 active case per million of population. So that would mean for the United States as a whole, 330 cases. And we're starting from, we might have 500,000 active cases now, and of course, a lot of unmeasured cases. So this is a rather bold goal to have. The objective is, if we can get it down to that level, we could follow policies similar to what's done in South Korea or Taiwan, and do contact tracing and simply isolation of the sick, and maybe those who've seen the sick, encountered the sick. And with these forecasts that I've just showed you, they're actually predicting that we would get there within, some cases, parts of the country in early May, some parts of the country maybe not until June. So we're looking at, say, 4 to 6 weeks to attain that goal, coming off of that, what I would call empirical forecast based on the decline in the growth rate that we've seen. And I wanted to be clear about this because, every day you can now obsessively watch the death numbers and think about, or the active case numbers, and think about, are we making progress, substantial progress, towards this rather ambitious goal of turning this epidemic into a kind of more conventional public health problem of dealing with disease outbreaks and, you know, in detail, and letting everybody else go back to work. Now we can ask the counterfactual, what would happen if we abandon social distancing now? Obviously well short of that public health goal of getting active cases down to 1 per million. The models that people are using are typically based on structural models of the disease that start with the concept that people can be fit into one of 3 categories, that they could be susceptible to the disease, that would be S, they could be actively infected and contagious at this time, that would be in category I, or they could be resistant. For this disease, which is new, you're going to get resistant because you got it and recovered, or you died. Or alternatively, if a vaccine is invented, we could convert susceptible people into resistant people directly with the vaccine. And a key assumption in these models that I'm going to come back to is the assumption that once you're in the category of being resistant, you're presumed immune to a second infection, and perhaps for a long period of time. Okay, so just to think about reading data on the where we are in terms of how the population is distributed across these categories, the S at the start should have been virtually everyone in the world, and the number of people infected at the start would have been about 15 to 30 people who would have picked up this disease in that market in Wuhan to start worldwide. And then this was data from yesterday at Worldometer, which of course lots of people look at for the data. The confirmed cases worldwide was about 1.6 million. So that's the people we're thinking of as being in the infected category. And the resistant would correspond to their closed cases, 805,000. If you look at those, 79% of them survived, and 21% of the closed and confirmed cases are ending in death. But that whole category of 805,000 is the resistant category. So the basic structure of the model, it's a bit like a model of unemployment. People flow into being infected and people flow out of being infected. The difference between this and a model of unemployment is that this is contagious. We typically don't think of unemployment as being contagious. So people start off in the susceptible state S, and they flow, they become new infections when they encounter infected agents. And there'll be certain parameters that are key to think about in the model. We'll have a beta T, which is a reduced form parameter that combines both the rate at which we interact with each other in society and hence bump into each other. There's the disease parameter itself, is how easy is it for me to transmit the virus to you when I bump into you? And then there would be questions like, are people using prophylactics? Are they wearing masks or not shaking hands or washing hands more carefully? Those are all things that would go into that transmission rate beta. And that's why I put a sub T on it, because that can change over time, not only for natural reasons, but because of mitigation and prophylactic steps that people might be taking. The model also has a simple assumption that infected people are walking around in the course of their daily lives and bumping into people at random uniformly And that'll mean that they'll only have the opportunity to transmit the disease to the fraction of people who are susceptible. Some of the people that they bump into might already be infected, so that is irrelevant, or be resistant. So again, that wouldn't transmit the disease. Then the other flow in the model is from being actively infected to recovering. And as I mentioned, you flow, in this case, before we have a vaccine, either because you survive the disease or you die from the disease. And we think of that flow rate, what we call the recovery rate, from I to R, which I denote by gamma on this slide, as a biological parameter. It has to do with, how long is the virus contagious in you when you're sick? How long does it take you to recover from it? So that's something that for now, since we don't have effective antivirals, is something we can't really alter for this disease. All of the social distancing measures or prophylactic measures we might think about would be loaded into the parameter beta T. So a key concept in this model is basically a comparison of the effective transmission rate, which is beta T times the share of susceptibles, ST over N, to this recovery rate gamma. If the effective transmission rate, or the rate at which we're acquiring new infections, exceeds the recovery rate, the infection grows. If it's smaller than the recovery rate, the infection shrinks. And that's really what's going to govern the transmission and the course of the epidemic. So people talk about this in the newspaper and in the literature all the time in terms of two numbers. We have a basic reproduction number and an effective reproduction number. The basic reproduction number is a comparison of this transmission rate to the recovery rate at the start of the epidemic, if you don't take any steps to mitigate its transmission, and if everyone that an infected person bumps into is susceptible to the disease. So you can think about this being essentially a comparison of the transmission rate to the recovery rate, initially in Wuhan in China, or say in January and February in the United States, when we had the disease introduced by people coming in from other countries, and they, unaware of what was going on, were bumping into others and transmitting the disease. So we think of this as being a characteristic of the disease mainly, and we have that an epidemic grows at the start if its basic reproduction number exceeds 1, if the transmission rate in an unmitigated state exceeds the recovery rate. Over time, though, we have that steps are taken and more people become resistant, so a smaller fraction of the population is susceptible. And so at any moment in time later in the progression of the disease, the effective reproduction number reflects this comparison of what would the transmission rate be from now on compared to the recovery rate. And if mitigation lowers that beta T parameter, social distancing lowers, the rate at which infected people are bumping into others, or if the population share that is susceptible drops low enough, if either of those two happens, then the effective reproduction number falls below 1 and the disease starts to shrink. So we actually refer to the case where the fall of the effective reproduction number below 1, when the share of susceptibles, S over N, falls low enough, as that's what they mean when they say herd immunity. This is a goal that a lot of people talk about, and I'll come back to in the discussions. Now, I've set this model up to try to do counterfactuals and think about what would happen if we stopped doing social distancing now. So two things that would be of interest would be what would we expect in terms of a peak infection rate? And what would we expect in terms of a cumulative burden of the disease? And what I mean by that is, what is the fraction of the population that in the long run would get infected? And I've updated parameters from my NBER working paper because the disease is evidently growing in the was growing in the United States much faster than it did in China. And so I consider a range of basic reproduction numbers between 1.6 and 3. And I'm using this to think about what would happen if we just abandon social distancing completely now. This is a graph that shows the fraction of the population that would be infected at any point in time over the next 180 days. And you see that the scenarios obviously differ depending on the rate that you anticipate, but we should get then in a relatively short period of time a big spike in the peak, in infections. That could, of course, have severe consequences for the healthcare system, even now with the time that they've had to prepare for this. And this is what Angela Merkel was referring to when she said that we should expect 2/3 of Germans to get the disease. This is showing the ratio of the cumulative cases to the population. And so in all the scenarios considered, over half the population ends up with the disease. In many cases, a very large fraction, almost everybody ends up getting the disease. So the forecasts, I would say, if we dropped mitigation that come out of standard models, would be for a lot of disease in a relatively short period of time, say here under 6 months. The alternative, of course, with mitigation, this is a graph, is that you kill off the disease early. So this is a graph from a paper in Cell Discovery that was applying a model of this kind to Wuhan very early on in the progression of the epidemic there. And what it shows in this graph is a total number of infections according to the model. This is shown first in purple, and then gray, and then blue, and then estimates are given in yellow and red. And what's in black inside this entire shape is what are the confirmed cases in Wuhan at the time. So this model was saying they had considerably more cases than their testing was showing, and it was growing quite rapidly. But you see, as we go from purple to gray to light blue to red, that they're having the effective reproduction number drop. And once they get it going below 1, either 0.9 in the red case or 0.5 in the yellow case, then the disease gets to die out. Even though Wuhan is a city of 11 million people, so 84,000 out of 11 million is not a large fraction of the population getting the disease. And this is the scenario that I would say, this is the type of picture that the public health people would like us to see in the United States coming from the social distancing that we've been doing. Of course, though, with the number of cases that we have, the peak that we're talking about being at a much higher level. Now, are we actually, you can interpret the growth rate numbers that we see in terms of deaths or active infections in terms of what is this effective reproduction number. So there's a website that gives you live estimates of the reproduction number by state. These are their numbers yesterday. I show you progression over time from New York and California. And then in the bottom panel across all the states, we're kind of in a situation right now where we've gotten the effective reproduction number down close to 1. So that means the infection's not really growing. but we don't really have it below 1 yet to make the infection shrink. So this is a number that I think is worth tracking every day. And in fact, I'm working with Jim Stock and a bunch of Harvard graduate students to do our own version of trying to estimate this effective reproduction number in real time and to give uncertainty bounds around it so that we could follow the progression of the disease in real time. So this raises the question. When I say this graph raises the question, we're kind of halfway to our goal. We've slowed the growth of this epidemic, but are we going to be able to actually get it to shrink to get us down to that goal of 1 active case per million? But there's also the question of, what happens if we did go through this scenario of lifting lockdown and just telling people to go back to work or go back to shopping. And so there, I think there's interesting experience. I'll give you a minute to read what's on this slide, but there's interesting experience from the 1918-1919 epidemic. A man named John Berry, who is a very prominent historian and has a great book about that experience, of the 1918-19 epidemic. He also has a nice article in Nature that's very short, published in 2009, where he makes the point that, as he says, fear not illness kept people at home. And he discusses the absenteeism levels, even in critical industries during wartime, such as shipbuilding and railroads. So, we have not seen this response yet in the United States. I'm not aware of it going on in other countries, but we're at a situation where we're having 2,000 to 2,500 deaths per day. If we thought about this going on at, say, 6, 8, or 10,000 or even 20,000 deaths per day, one has to wonder how Americans would react and whether the alternative of lifting lockdown now would actually lead to a recovery of economic activity in the near term. Another factor that comes up, and I think is of considerable interest, is just how dangerous is this disease? I mean, you'll notice what I showed you with that SIR model is that I didn't really distinguish between people who recovered, who were resistant because they recovered and people who were resistant because they died. In part because I think it's very difficult for us to know what the fatality rate of this disease is without an accurate measure of what the true infection rate is. You will see estimates of the infection fatality rate everywhere between 1% and 0.1%. The 1% number would come from something like the Diamond Princess, where we had the population was on the cruise ship was controlled. There was no inflow and outflow, and we were able to test everyone on the Diamond Princess. An infection rate, but people would argue that that was an older population. An infection fatality rate of 0.1% might come from the aircraft carrier Theodore Roosevelt, where again we had everyone on the ship tested and no inflows and outflows of population. But of course, that population was very young, and hence it was not, the young seem to be doing quite well with this disease. That might be a relevant experiment for colleges thinking about opening up in the fall. The scene might be very much like the Theodore Roosevelt. But any one of those fatality rates leads to quite a large number of fatalities in this first round of infection of the population. If we just use as a rule of thumb that we would expect within 180 days of unconstrained transmission that 2/3 of the population at least 2/3 would be infected, we'd be talking about somewhere between 220,000 and 2.2 million deaths. So that's a pretty wide uncertainty bound, but I would say even 220,000 is a pretty high number. Now, what's in this table is data that New York City released about the deaths there. And what's striking about the table is that in the third column, it says with underlying conditions. And what you see is that a very large portion of the deaths, regardless of age, are coming in with some underlying condition. It's listed in the notes: diabetes, lung disease, cancer, etc. And so these data do, raise a question that perhaps an approach that's tailored towards protecting the vulnerable, those with underlying conditions, might be something that we need to shift to if we need to come up with some kind of alternative plan to the current kind of broad plan of keep lockdown going until we can get the case count way down. But then what happens in the long term? And so what I'm showing here is a graph. This is probably, people have seen this. This is a fatality rate from the 1918-19 epidemic in the United Kingdom. And it's quite evident that the disease came in 3 waves at that time. And apparently, influenza-like diseases tend to come in waves, and they tend to have a lot of variation in their transmission speed that's natural, could be related to the weather, could be related to other factors that may or may not be connected to mitigation steps. And I emphasize this because although we've had a lot of encouraging news around the world from the bending of these curves, I guess I did mention earlier, there is this possibility that what we're seeing is not the benefits of social mitigation, but perhaps a common factor that's being driven by something in the natural evolution of this disease that we don't fully understand. Now, I don't intend this picture to be a prediction that we're going to have a much more severe second wave. This is just, what happened in history. It is kind of interesting that you have this very big second wave comes in the fall, and then of 1918, and then it actually died down there in the winter of 1918 and came back again in the spring of the winter of 1919 and came back in the spring of 1919. So this was not the case of, summer and winter fluctuations, because we see a lot of death in a relatively cold time, and then a pause, and then a bunch more death again in the spring. So I want to emphasize this as anytime you're interpreting any kind of numbers, don't overinterpret in terms of causal impact. It'll take a lot of research to figure out the causal impact of mitigation. But if we think about longer term disease scenarios, there's an article that came out on April 14th in Science that basically asked the question, what if immunity is not long lasting? And what if the transmission of this disease has a seasonal pattern that's similar to related coronaviruses? They're listed at the bottom of the chart here as OC43 and HKU1. And so the team that wrote this Science article simulate a somewhat more complex disease model where instead of having the category R for resistant be a permanent state of affairs, it's something that is temporary, so you transition back to being susceptible after some period of time. And there's 5 panels in this graph that correspond to 5 different scenarios of disease progression under different assumptions about the seasonality of transmission and the persistence of your immunity to the disease. And in each graph, so the blue line and the red line in each graph is showing patterns having to do with known viruses, and they're, thinking about different scenarios there about how all of these things will co-move. But the item of interest might be the gray or darkish line, where in the scenarios that they're considering, say in panel A, they're thinking at the spike of disease prevalence this year, we would have 7.5% of the population infected at the peak. But then in 2021, 2022, 2023, et cetera, we would just have echoes. They would be about 1/3 to 1/2 as large. In panel B, the persistence of your immunity is a bit longer, so the echoes are much smaller. The most optimistic scenario is in panel D, where immunity lasts long enough that the disease actually disappears. So what I would say, if we think about macroeconomic impacts, there's a lot of uncertainty as to what's happening in the long run. So to finish up, it seems to me in the near term that we have what I'll call the public health strategy of continuing with extreme social distancing for 6+ weeks to try to get active infections down to a very low level and then turn mitigation over to a large public health effort. And that would have to be carried out for years. The alternative strategy, if you lifted lockdown immediately, this is an alternative. We would probably see a big spike in deaths and infections in the near term. And I have to wonder if we would get much economic benefit out of that, if fear would keep people at home. And I have to wonder whether we would get much benefit in terms of herd immunity if immunity is not long lasting. And it does seem clear, given the possibility that immunity is not long lasting, that we would still need the public health effort long term under either strategy. So when I personally think about these two, I kind of vote for the first strategy, but I would say on a daily or weekly basis, I might reassess that if we don't see the effective reproduction number falling significantly below 1 soon.